Good morning, everyone. The ASFA webinar will begin in about 2 minutes. Welcome, everyone, to ASFA's last webinar of the dedicated webinar series honoring the Apheresis Awareness Day 2022. The purpose of Apheresis Awareness Day is to raise awareness of apheresis medicine and pay tribute to many donors, patients, and apheresis practitioners that have dedicated their lives to saving others by using evidence-based practice to advance apheresis medicine. Today's webinar is entitled Managing Through the Pandemic, Experiences of a Hospital-Based Blood Center, presented by Dr. Grace Sese. My name is Ernest, and I will be your webinar moderator today. Before we get started, I'd like to briefly go over the format of this presentation. There will be 2 parts, a 45-minute presentation segment and a 15-minute Q&A. Please note that today's webinar is being recorded. I would now introduce our speaker. Dr. Grace Sese is the Medical Director of Innova Health System Apheresis Services and Innova Blood Donor Services, with collection of over 60,000 whole blood and over 110,000 blood products. Dr. Sese, you may begin your presentation.
Good afternoon. Can you hear me, Ernest? Am I on?
Yes, we can.
Okay. Good afternoon to all. Thank you for the invitation. Today, we're going to share our experiences during the pandemic as a hospital-based blood donor center. So learning objectives include the definition of the different challenges we faced during the pandemic and pathways of survival and how we conserve blood during the shortage. And in the end, I would like to give credit to the teamwork of all the team members and all the blood donor centers in the country. So first of all, I'd like to introduce who we are. We're Innova Blood Donor Services, established in 1965. We're located in Virginia. We have 3 fixed sites, and we're right next to the Maryland and DC border, which will play a role during the convalescent plasma collection. So we began in 1965 with a collection goal only of about 300 donors annually, but based on the support of our community and Innova team members, growth has been exponential through the years. I'm proud to say that we're one of the largest hospital-based blood centers in the country. We have over 55,000 donors annually. We do in-house donor testing, pathogen-reduced technology for single donor platelets, molecular red cell phenotyping, and many others. So we're the blood supplier for the Northern Virginia Emergency Medical Services Council, both by air and land transport services. And we're also a member of the Blood Emergency Readiness Corps, which is a group of US-based community blood centers working together to provide an emergency reserve of blood products to respond to mass casualty event. So we're under the Innova Health System, located again in Northern Virginia with a population of 3 million. It is a nonprofit healthcare provider with 5 hospitals. We have Innova Alexandria, Innova Fair Oaks, Innova Mount Vernon, Innova Loudoun, and Innova Fairfax Medical Campus, which is the largest hospital with 1,100 beds. Our total team members for the entire Innova Health System hospitals is about 20,000, with over 2 million annual patient visits and a total licensed beds of close to 2,000. So at Innova Fairfax Medical Campus, we have level 1 trauma center serving the entire Northern Virginia. We have the level 4, the highest level for neonatal intensive care unit, caring for premature babies and critically ill newborns. We have the Innova Shark Cancer Institute, Innova Sickle Cell Disease Center, Innova Heart and Vascular Institute, Innova Apheresis Services, of which I'm also the medical director, and the multiple outpatient infusion centers. Why I mention this, it just shows the magnitude of the services that require blood through the years. So I'd like to share a journey from pre-pandemic, pandemic, and 2021 year to date. So pre-pandemic was wonderful. Pandemic, we entered into a dark phase in our blood center world. It kind of turned our lives upside down and really spurred the global health crisis. And I'll be talking about our 2021 data. So these are the challenges we identified during the pandemic. We had challenges with donors. As you all know, there was donor decline, team member challenges, blood supply challenges. Communication wasn't, I would like to say this is really the key element. I don't want to say it's a challenge, but it partially was. And then the supply chain challenges, collection of convalescent plasma, and of course, our precious patients that we serve. And lastly, our sustainability. So just a brief history of the COVID-19 pandemic. The SARS-CoV-2 virus first appeared on a small scale in November 2019, with the first large cluster appearing in Wuhan, China in December 2019. The outbreak in the United States was proclaimed a national emergency beginning March 1, 2020. And as of March 12, 2020, close to 2,000 people from 47 states have been infected with the virus. The World Health Organization declared COVID-19 pandemic on March 11, 2020. At the time, more than 118,000 cases infected with COVID and 4,291 deaths in 114 countries around the world. So we were really, it was really a dire situation. So the first challenge that we had are the donors. There was significant reduction in blood donation during the pandemic due to mandatory lockdowns and donor concerns for personal health risks. So we took safety measures in collaboration with the health system infection control to maximize donor safety and minimize the risk of infection. So that what did we do? We made sure that there was absolute mask requirements in the collection facilities, social distancing of at least 6 feet, implementation of disposable donor education materials that are required FDA reading, implementation of temporal thermometers instead of oral thermometers and single-use pens, and oxivir, which is an accelerated hydrogen peroxide, as provided or as recommended by the infection control at the hospital. Oxivir, it's a disinfectant, and the manufacturer's claim is that within 15 seconds, because it's specific for SARS-CoV-2 virus, it disappears. And also we had the electronic donor history questionnaire. So for team member challenges, these were the mitigation strategies. We had infection control procedures implemented. We screened team members consistent with latest Centers for Disease Control and Prevention guidelines. So we told the team members to quarantine if they were COVID-19 positive, do not come to work if you are sick. You need to monitor and report COVID symptoms to the team member health. And we also provided personal protective equipment such as masks, goggles, or face shields. gloves, and impermeable lab coats. We gave them multiple lab coats, and they were sent to the hospital. Pretty much the hospital took care of them for cleaning. So we also did daily temperature checks and symptom attestation, and we had a checklist for that. We also made sure there was social distancing in all settings throughout the donor center unless performing procedures. We also limited team member presence in shared spaces such as break rooms and shared offices. And we prevented large gatherings. Instead, for meetings, we went on Zoom. So there were supply chain disruptions. Our initial challenge was obtaining adequate personal protective equipment at the start of the pandemic. It was difficult to find gloves, Band-Aids, Cobands, surface cleaning materials, masks, face shields, and hand sanitizers. The global supply chain and group purchasing organization were overwhelmed with orders. Supply was low due to lack of raw materials for these manufacturers. So blood bags, apheresis collection kits, reagents, all these were delayed, but thankfully we never turned away a donor during those times, so which we were very lucky. Of course, when times were dire, we sought other resources such as alternative vendors. So for the blood supply, pre-pandemic, our collections were wonderful. In 2020 and 21, really, this was really a dark time for not just for us, but for all of us. And you can see we saw a big dip in our collection. And in 2021, we saw a bigger dip. And I think this was just because offices and businesses were open in 2021, some of them, and schools too. But I think it's just like a holding pattern where, you know, owners of businesses were still hesitant to have outsiders come in to have blood drives and so forth. So we were really in bad shape. So stay-at-home orders were issued from March 1 to May 31st, 2020 by all 50 states, including the District of Columbia and the 5 US territories. We had no mobile blood drives from March 12 to June 15, 2020, which has really contributed to significant decline in our donors. So what we did was to expand our blood center hours at our 3 fixed sites. So we also kicked in the inventory management. It was very critical. We communicated multiple times daily with our blood banks regarding daily blood utilization and inventory levels. Daily inventory report was run in the lab information system. We have the soft lab system, and we monitored blood bank orders and ensured it was only to maintain par levels if applicable. We also increased the inventory levels at the largest hospital blood bank, which is Innova Fairfax Hospital, to assist in supplying products to other Innova blood banks close to the facility. We implemented additional mitigation strategies during the blood shortage, such as our imminent blood shortage procedure for when the inventory levels were down at 75, 50, or 25%. An example of this at 25% inventory was that we recommend ongoing evaluation of patients receiving massive transfusion, decision support for terminating MTPs, split RBCs and platelet units as needed. So it was really an awful time, not just for us, but for everyone, I'm sure. So this is the source of our blood products in 2021 versus 2022. I'm sorry I couldn't show 2020 and 2019 as we changed our computer system. We made it better, of course. And in 2021, typically our source of blood products, the community, the high school, the offices. But as you can see, the high school really dipped down to almost less than 50% compared to 2022. And our community also, they rallied, but it wasn't enough. But in 2022, we saw a big change. And it was wonderful to see that our religious organizations helped us during the pandemic. So different donor behavioral patterns during the pandemic that we have identified. So communication was key. This is very important. So we closely collaborated with Innova Operations Center that monitored COVID-19 tactical operational preparedness and response activities and issues in accordance with COVID-19 Coordination Center guidelines. This was our source of government and community affairs update and national authorities as well. It was staffed by senior administrative, nursing, and other service line leaders. They monitored team member health and safety, supplies, shortages, manpower deployment, daily communications, PPE needs, patients, and others. We also had town hall meetings with clinical service lines, especially surgery. We joined their town hall meetings regularly to inform them of our inventory. It was very important to them. As you all know, elective surgeries were canceled and any procedure that required blood. And we also had the Innova Daily Huddle messages, not only to recruit donors, but to let them know also our inventory. So this is an example of our communication to Innova leadership on March 13, 2020 at 9:53 a.m. So we let them know that we were at 60% of inventory due to many cancellations in the last week. We've lost many high school blood drives, and our collections in our centers were down by 25%. And our professional sports team that we partnered with, we lost 900 appointments on March 28th. This was canceled and modified. So part of our communication to Innova leadership included mitigation strategy plans as well. We told them that we will reach out to the media to encourage donors to come to our centers, consider opening our fixed sites 24/7, maintain constant communication with each of our hospital blood banks to evaluate blood inventory levels on a daily basis, postpone or cancel elective surgeries, especially those that may have a reasonable chance of using blood, consider the necessity to split units of red blood cells and single donor platelets, and utilize cell savers where appropriate. We also encourage them to remove O-negative units for some of our Innova Emergency Care Centers, or ECC, and also recommended postponing or reduce outpatient transfusions, which was very difficult because we have a large oncology center and lots of infusion centers. Also consider reducing 2 units RBC transfusions to 1 unit, and review transfusion criteria, consider lowering minimums. So this was really difficult, but we had to do it. So this was very critical to communicate to the leadership. So again, we also, the Innova Blood Donor Center marketing recruitment team was in close collaboration with blood drive coordinators and Innova Health System marketing team, and utilized many tools of communication to engage the community to donate blood. Social media, multiple television and radio interviews were done. I was one of them being interviewed to encourage blood donations. And to show a good example, this is Dr. Stephen Jones, who's the CEO of the entire Innova Health System. He is a wonderful advocate of blood donation. So we were so busy at the blood center, not only trying to conserve our blood, but we were also collecting convalescent plasma. Studies then suggested that CCP donated after recovery from COVID-19 was a therapeutic option for acutely ill COVID-19 patients due to the presence of neutralizing antibodies that help clear the SARS-CoV-2 virus. At the time, pathways approved by FDA in the CCP study included clinical trial for investigational new drug, and the expanded access, as you all know, was very popular under the Mayo Expanded Access Program. But there was also a single patient emergency investigational new drug, or EIND. We were the collection center for convalescent plasma for hospitals in DC, Maryland, and Virginia enrolled in the Mayo EAP. And we also maintained a separate CCP inventory for a single patient EIND at Innova hospitals. In May 2020, Innova Fairfax Medical Campus participated in Innova Research IND clinical trial. It was entitled Open Label Treatment of Severe Coronary Virus Disease 2019, with convalescent plasma collected from individuals with documented infection and recovery from COVID-19 or SARS-CoV-2. It was really a busy time for the Blood Center. So we had different recruitment pathways. I don't have to go in details, but there was a fight is in us. And we also had our separate website for potential CCP donor inquiries. We established pre-screening questions, and we also obtained a list of recovered and discharged COVID-19 patients from Innova hospitals for CCP donor recruitment. In September 2020, COVID-19 antibody testing was added as a value-added test to encourage plasma donations from CCP donors. So what about our patients? We had to take care of our precious patients. Despite the blood shortage, we had to think of ways to make sure that the care was continued for them. So the low titer whole blood was that we implemented this in December 2019, which was very timely during the pandemic. So we provided a low titer O whole blood to assist with trauma and to reduce the utilization of blood components. So this was utilized for massive transfusion protocols, and we provided this to the emergency medical services for field trauma. So for apheresis, as the medical director, there was a day I spoke to the senior director and she said, Grace, what can we do? Because we cannot sustain, this is unsustainable. And so I said, okay, so we reduced the fluid balance from 100% to 95% for patients undergoing therapeutic plasma exchanges. So in patients with thrombotic thrombocytopenic purpura, we only gave 95% of fluid balance. So with plasma replacement, we reduced the number of plasma. And we either use mixed replacement fluid of plasma and 5% albumin. At the time, there was also supply chain disruption for 5% albumin. So this also helped with other patients just receiving 100% 5% albumin as replacement fluids. And for our sickle cell disease patients on red cell exchange, we instituted partial red cell exchange. We also collaborated with outside vendor to introduce patient blood management team. We implemented single unit RBC transfusions with engagement of executive leadership and licensed healthcare providers to make this a success. So for the sickle cell disease patient, we optimized the use of blood due to the critical blood shortage by introducing partial red cell exchange for sickle cell disease patients on maintenance red cell exchange in an outpatient setting. They were clinically stable, and the red cell replacement volume was reduced by 50 to 60%. All patients were made aware of institutional policy with regards to partial rather than full exchanges. All patients indicated understanding and willingness to proceed with partial red cell exchange. Indications were for frequent acute chest syndrome, history of stroke, history of priapism, and for those with frequent severe chronic pain, necessitating use of pain medications. And all our sickle cell disease patients new to Innova Blood Bank database were placed on a CE and KEL match protocol. Our preliminary evaluation suggests that instituting partial red cell exchange was both effective and safe. So in October 2020, a health system-wide comprehensive patient blood management was implemented at Innova. It was implemented as a national quality and patient safety initiative focused on evidence-based transfusion practices and proactive strategies. It was designed to reduce the number of transfusion utilizations and improve patient clinical outcomes. So we socialized this fact to all the stakeholders, the licensed healthcare providers, the chairman of the different clinical service of the different services. So that US hospitals overtransfuse by 40 to 60%. And this is linked to a higher rate of infections, organ injury, heart attack, and even deaths. So less is more, a more restrictive approach to transfusions not only saves blood, but also saves lives. Transfusion is a transplant, while blood transfusion saves lives. Unnecessary and avoidable transfusions contribute to patient harm. We also socialize this that when there's a need for transfusion, less is more, what clinicians need to know. 1, not 2, transfuse the minimal amount of RBC units, followed by clinical assessment for the need of additional transfusions. And also 7, not 8, transfuse RBC at hemoglobin less than 7, or at least minimum of 7 in stable patients. So this was part of restrictive transfusion parameters. And we did an RBC metric trending, and I'm very proud to say it was a very successful implementation of single unit RBC transfusions at our Innova Health System hospitals. We went up to 85%, as you can see the graph. There was wonderful engagement by all the stakeholders, the licensed healthcare providers. Of course, we ran audits on all their orders. We spoke to their chairman, department chair, but overall, it was a successful patient blood management that we instituted at our facilities. So recently, Dr. Shander Alex Hoffman et al. Wrote this article in Anesthesia and Analgesia that patient blood management, entitled Patient Blood Management, Improving Outcomes for Millions While Saving Billions. What is holding it up? And in 2021, there was a policy brief released by World Health Organization about the urgent need to implement patient blood management. So the last challenge that we had was sustainability. It was really difficult to predict if a sound productivity goal was realistic or attainable during the pandemic. I'm sure we were all in the same boat. It was really very difficult. But as part of a high reliability organization aiming to achieve safety, quality, and efficiency goals, close partnership with health system leadership was critical. We shared the same Innova mission, vision, and values. And also we had resource sharing with access to other health system services. We had human resource support, and of course, the successful implementation of patient blood management. And we relied on the 5 Innova hospitals for blood drives, which really helped us with increasing our blood supply. And as you all know, community outreach is very important. Donors like patient stories. So we try to recruit donors for patients, for instance, needing, their particular blood type, like O negs and all that, for pediatric patients that are leukemic, requiring multiple blood product transfusions. They come and donate. They really like that. It really tugs their heart. So despite the challenges of an unprecedented pandemic, I'd like to say that the average the blood donor center productivity was over 100%. We were so thankful for that. But as you can see, our productivity went up in 2020, actually, more than 2019. I'd like to think that also the BARDA payments also helped a lot in the this is productivity, but again, as you all know, BARDA paid for the convalescent plasma. But now we're still not there in 2022, but I'd like to be optimistic. We still have a few months to go before the end of the year. So that's our sustainability. And so where are we today? Like I showed earlier, we're still not there compared to our 2019 pre-pandemic annual collections, but with a few months left, hopefully we can rally and bring that annual collections close to 2019. So we use we're members of the Blood Centers of America. I'm sure America's Blood Centers did the same thing, but they provided the daily RBC supply. I'd like to think that a 5-day supply is good, but in March 1, 2020, you could see the blood supply load. It was tottering. It wasn't really ideal. And 9 days later, we saw an increase. So what's with that? I think it's because donors were hunkered down, patients were hunkered down. Nobody was going to the hospital for surgeries, for their cancellation of elective surgeries. So I think that's why we're seeing this nice RBC supply by days. And 3 months later, of course, we saw a dip in the RBC day supply. And as of September 23rd, we're still low. We're still less than 5 days RBC supply. And so because of that, we continue to plead for donor donations, and we use this as recruitment, the critical blood shortage in your community. So this last slide is really for the teamwork, the team members, the donors who rallied to help us with the blood supply, and overall, just the whole entire nation, all the blood centers in the entire country, just helping each other. Despite the darkness of the pandemic, we were all there for each other, which was a great camaraderie. So thanks to all. And I said initially in my slide that I'd like to see a rainbow. Yes, there is a rainbow, but it's not complete. But we're not there yet, but we're getting there. I'm very optimistic. And I just want to show this. It's just so funny that Innova Health System share this or send this to all the team members. And I guess for well-being, I'm sure we're all COVID fatigued from the pandemic. And this is just a wonderful information, recharge from pandemic exhaustion. This is care of Duke Center for Healthcare Safety and Quality. And lastly, I'd like to acknowledge Nick Lilly, Director of IBDS Operations, Gina, who's our Transfusion Safety Officer, Rhoda, who helped me make the slides, and Terry Craddock, our Senior Director at the Donor Center, and the Acumen team. So thanks to all. That's the end of my slide. Thank you so much for your attendance and attention. Ernest?
Yes, so that concludes our presentation segment. We will now start our Q&A. So for anyone who has any questions, please type your question in the chat box. And I believe, Dr. Sese, we have a guest with us you would like to introduce.
Yes, one of the panelists, I invited Nick Lilly, who is our IBDS Director of Donor Operations. He's just done a great job during the pandemic and worked with me. And so I'm in his one of the panelists, so he will answer any questions that you have for both of us or for one of us. Any questions?
So Dr. Sese, we actually have one in the queue.
I can't see it.
Well, I've already turned off your screen share, so you can turn off, close out from your presentation slides.
Oh, got it. Okay.
How about this? I'll read this one out loud, and then perhaps you can take over from then on. So we have a question here from Sharda Gupta. I'm sorry if I pronounced that wrong. And this individual's question is, are you still collecting convalescent plasma?
No, we stopped collecting convalescent plasma. The reason being, our physicians were no longer interested in using it, and so we stopped it. We had a stockpile that we converted to regular plasma. Thank you.
So I don't see any new questions yet, but perhaps do either of you want to add to the presentation, or maybe such as like extra tidbits you want to provide, or maybe even questions for the audience?
Yeah, I just want to know if there's any hospital-based donor center that's attending this webinar, and I just want to know if it mirrors to what we've done to what they've done. Is it similar to what we did, or was there anything that they can add to what we did that will benefit from? Hopefully it doesn't happen again, the pandemic. Are there any hospital-based donor center attendees?
The audience is still quite quiet. Nothing's come through yet. Or maybe they're all typing in long responses.
Maybe they did the same process that we did. How did you do during the pandemic? How are you all now? Are you still collecting convalescent plasma? And where is that?
So we have one audience member, Melissa, mentioning that that she's not hospital-based at Impact Life, but they did collect CCP, and they have not been collecting since April 2021.
Okay, yeah, just like we did.
I guess I'll ask this question. Of the centers or individuals that are out there, are you guys taking any additional steps to perhaps improve your collections or your community involvement?
Well, I guess while we're waiting for responses from Dr. Lilly's question, we do have a couple more comments coming in here. So our fellow board member, Dr. Nicola Cui, notes that we were collecting convalescent plasma under an IND, but we have since stopped, and she's from the hospital of the University of PA, Pennsylvania.
Yeah, thanks, Nicole.
And then another comment we received, actually, Dr. Akui just asked, Dr. Lilly, do you mind repeating your question?
Yes. So I was asking, who out there may have taken some additional steps to recruit donors, and perhaps of those steps that you've taken, what successes have you seen to increase community involvement, within your centers?
All right, now we have more comments and also a question. Let me just address them in the order that they were received. So our next individual says, we did not do partial exchanges, which seems like a very good way to conserve units. Our donors still have to be COVID vaccinated. And then our next one is from Cherry, and this individual's response is, I work at a pediatric center. For the therapeutic side, we do not do donations, but we do encourage our staff that utilizes donated products and their families to promote donation, along with personal testimonies on social media.
We mirror that. We do that with our sickle cell disease patients, sickle cell disease patients. We encourage their family to reach out to their community, family members, their friends, group of friends, to host blood drives for us. And we educate them about the blood shortage and the need for blood from their population, because we provide C and Kel negative units for our red cell exchanges.
And certainly utilizing social media has been very helpful in garnering additional donors. And certainly we do also rely on local media to share the stories of our patients, and certainly meeting with our patients from time to time, and sharing those stories within the health system does also help us to collect additional units and have additional community involvement across our organization.
Right, so as I'd mentioned, we did have a question in the queue. So here is the question from Amanda. Are you continuing to perform partial procedures for patients with sickle cell disease and TTP?
Yes, we have not stopped because our inventory is still not in good shape. So we have continued. In fact, it was I presented this as an oral presentation for the sickle cell research group in June, and hopefully a manuscript is underway, so we can share more what we've done for a partial red cell exchange. It's just a small study, but we are now, anytime we recruit new patients, sickle cell disease patients for red cell exchange, we just put them on partial red cell exchange. I mean, the numbers are good. They're post-exchange hemoglobin electrophoresis. We monitor them pre and post, and they're good. And they're doing well. There are no breakthrough crisis between durations of sickle cell of red cell exchange. They're not admitted to the hospital, so it's really good. And we're saving blood as well for our other patients to utilize. And for the plasma exchange, yes, we continue to use a 95% fluid balance for our plasma replacement fluid for our patients with TTP. And even for those receiving 100% 5% albumin, we put them on 95% fluid balance.
And certainly patient blood management has really been a big factor in aiding in those efforts. And essentially, we've been able to treat more patients over the last couple of years with essentially almost the same amount of blood products from the community. So as our hospital censuses continue to rise, we do want to continue to be able to have additional community involvement. So patient blood management has really made that very much possible.
I agree. It was difficult at first to implement it because it was a culture change. As you know, it's difficult to change a culture of the utilizers, of the users, but with the help, engagement from the leadership, executive leadership, we were able to convince them and get their attention. Department chairs, all the physicians, all different specialties. So it was wonderful engagement by all. So that's why it was successful for us.
So we also have a comment here that pertains to Dr. Lilly's original question. So it's the individual's name is Deirdre, and just noting that they relied heavily on, well, they relied on their employees quite a bit, and I believe it refers to getting referrals for the blood bank. Blood center.
Yeah, that was really key. As a hospital-based blood center, we have all the other hospitals that help us, that rally to help us during blood shortages as well. We can, of course, not during the pandemic, but once it subsided a little bit, they were willing to let us go into their facilities and have blood drives. So that was very helpful to the inventory.
Certainly, and you know, probably the biggest challenge that we see nowadays, and it's starting to go down quite a bit, is being able to get inside of facilities. And so getting to places where they have ample amount of parking so we can have our blood mobiles parked, you know, has been a challenge. But I would certainly say that, you know, between referrals from the community, referrals from our team members, and then just, you know, providing certain small value incentives to those individuals as a thank you for donating. That has been very helpful in our efforts.
All right, we have another question coming from Amanda, and she asks, with the partial red blood exchange procedures, are you trying to achieve a lower FCR or HCT? How do you determine the volume of replacement to use?
Yes, so we usually give our replacement volume, we decrease it by 50, 60%. Of course, the FCR, it was 50%, hemoglobin S was 50% higher from pre-exchange hemoglobin S. And our FCR, we usually put like 35 to 40%. Also, I typically use 35, 40% when I do a red cell exchange. Yes, it was higher. The FCR that we enter is higher, but we do a hematocrit of 30. And then through time, I monitor the hemoglobin S, the pattern of hemoglobin S, the FCR, and then I make a decision whether, you know, should we increase the number of units to 60% instead of 50%? So it's just a continuum of care. You have to monitor those results. But the patients are fine. Like I said, there are no breakthrough crises. Sometimes it's just the patient weight. Sometimes 5 units may not, or 50% may not be enough, or sometimes we have a tendency to give 40%, but we try to retain a 50, 60% replacement fluid for our red cells, for RBCs. Yeah, it's a good question.
So that's it for all the questions or comments we have so far, but I do see we still have about 10 minutes left until the hour. We may not necessarily need all 10 minutes, but if anyone has any other questions or comments they would like to add, again, please type them in the chat box and I'd be happy to read them out loud for our panelists.
Or you can send me an email, Ernest, if they have additional questions later on. My email is grace.sese@innova.org if you have additional questions.
And I'll mention later on as well that we will be sending our usual webinar evaluation email. And so even if you didn't catch Dr. Sese's email address then, you can feel free to reach out to head office directly and we'll forward that question to Dr. Sese. So yeah, maybe
Again,
I'll just...
Thanks to everyone.
Sorry for cutting you off. I was just saying it's like, yeah, I still don't see any new questions. I was gonna wait for another 30 seconds, but if everyone agrees, maybe we do wrap up a little earlier.
Okay.
Dr. Kui just said, thanks to the panelists.
Thank you.
Thank you.
So I guess with that, Dr. Sese, did you have a closing remark that I accidentally cut you off at?
No, I just want to thank everyone for attending. And in the end, it's just, teamwork by all the donor centers, whether we're hospital-based or not hospital-based. We're all in this together. We're our community, and we're going to help each other.
Excellent. And so with that, I will thank everyone for joining. So both our panelists as well as all of you, our audience. So as I had mentioned, the webinar evaluation and instructions for collecting your continuing education credits will be sent to you in an email later today. Thank you and have a great day.
Thank you. Thank you, Ernest. Bye-bye.